That's great. We are live on YouTube also now. Prof. Bildam is online with us now. Andy, how are you?
Hi, very well, thank you. And you?
That's great. Fine, thank you. So we have just went live. We've just started, and we have about 250 people already online. So welcome, everybody. This is the 45th webinar, iBreastBook. So this is about risk-reducing surgery. So want to check that we're doing something different each time. Can you check that the question and answer section and the chat function are both working? So if you can put something for me on the chat function, and if you can put something for me on the Q&A function. Now we have great 4 speakers. So we have Rachel O'Connell from the Mazen in London. We have Jill Dees from the States. Jill will join us a bit later. She is in a meeting. We have a Cicero Urban from Brazil, and Cicero will join also a bit later, and he's also in another meeting. We have Vishika Tripathi from Guys in London. We have Prof. Andrew Bildam from Manchester and London in England. The usual suspect, we have Ricardo Pardo, and Ricardo is from Bolton, and Ricardo is running the Spanish channel today for us. So if you want to hear the talks in Spanish, just go on the globe on the lower part of your screen, click on that, and choose a Spanish channel, and Ricardo will tell you everything in Spanish. And the usual suspects will have Ash Kotari joining a bit later. I think both Ash and Jill are in the same meeting. So whenever that meeting finishes, they'll join. We have 4 lovely talks, each about 10-15 minutes. The first one is Vishika Tripathi, and Vishika is going to talk us through genetics of breast cancer. Vishika, the next 15 minutes are all yours.
Lovely. Hi, everyone, and thank you so much, Yasan and colleagues, for having me. So I'll just try and share my slides. Is that okay, your end?
Perfect.
Okay. So we're going to spend the next 15 minutes just thinking about the landscape of breast cancer genetic susceptibility, and hopefully that will help to inform some of the later talks and questions that you might have for your patients when you're considering things like when to discuss risk-reducing mastectomy, particularly contralateral risk and any risk-reducing mastectomy and recon options. So my first slide is just a reminder really about how genetic predisposition to disease is placed. And this is not unique just in the breast cancer spectrum. And you can see that actually we are looking at a lot of common variants that occur in the general population. So that's the pink circle right at the bottom there. And they are frequently found in lots of individuals in the population, but actually the amount of risk they confer is fairly low. On the other hand, you have some rare variants that are found in, a small subset of the population. So they are rare or very rare, and the risk that these would confer are much higher. So that's the blue sort of circle right at the top there. Here you go. And when you're thinking about things like risk-reducing mastectomy and reconstruction, in the clinical genetics area of practice or scope of practice, we tend to usually see patients that are carrying high-risk rare variants that cause Mendelian disease, most of whom might have a family history of breast cancer or related cancers such as ovarian cancer. In the UK, the sort of eligibility criteria to access genetic or genomic testing for breast cancer is nationally set, and we are guided by this sort of traffic light system, which tells you the level of evidence that goes with each gene disease association and what the confidence level is for each genetic variant as well. So what I'm showing you here is the current testing eligibility criteria for both living and deceased individuals with breast and ovarian cancer. And this has just been updated as of yesterday. And you'll see that there are 5 susceptibility genes that are tested in the UK routinely, including BRCA1, BRCA2, CHEK2, PALB2, and truncating variants in ATM. The same sort of applies to women with ovarian cancer without breast cancer. But the reason I'm putting this up is frequently, if you canvass a family history from your patient with breast cancer, they may actually report a wider history of ovarian cancer. And that becomes particularly important when you're trying to establish whether there might be an inherited pattern that warrants genetic testing in the first place. Most of the associations that we see in the breast cancer context are in relation to epithelial ovarian cancers, and that's where you would generally tend to offer germline testing for variants in BRCA1 and BRCA2. Some of the other predisposition genes that you're seeing at the bottom of the slide there cause a different condition called Lynch syndrome, and we won't be covering that today because that's less relevant to the breast cancer side of things. In terms of what the landscape looks like when we're thinking about what susceptibility genes increase breast cancer risk, currently there are 12 susceptibility genes that are known to have a definitive association to cause breast cancer risk or elevated breast cancer risk above that of the general population. Not all confer what we deem a high level of risk. Some of these are genes that confer a moderate level of risk, but again, there are subtleties to that, and I'll use some case examples as we go through. But you'll see that from this list, actually, in the UK currently, as I said, 5 genes are tested, but equally, there are some bigger and wider panels that might be tested elsewhere in the world. So what are some of the other cancers or features that you might see in that individual or family when you are in your clinics with your breast cancer patients? Well, actually, it's equally important to not only ask about breast cancer, but also about some other related cancers, because that can give us a really quick sort of indicator as to whether there might be a distinctive phenotype or a genotype-phenotype association in relation to a particular genetic variant in any of these 12. So you'll see, for example, with BRCA1 and 2, we know that these families are likely to report a history of breast cancer, ovarian cancer, pancreatic and prostate cancer. But actually, if you look at CDH1, for example, which is, of course, much rarer, you might get a pattern of lobular breast cancer and signet ring gastric cancer, which are quite pathognomic of CDH1 carriers. So this is just to give you the sort of broad spectrum of other things that it would be important to ask your patients and families about if you're thinking about the presence of an inherited susceptibility. What is the contribution of these genetic variants, these gene-specific variants, to the whole sort of landscape of hereditary breast cancer? Well, we know that still, by and large, the vast majority of it is contributed by BRCA1 and BRCA2 pathogenic variants, but actually now we also have PALB2, which was sort of discovered in 2014, and I'll tell you a little bit more about that soon, which is starting to contribute to families that you might have anticipated them to have a BRCA variant. You test and they're found to be negative. So this is the third gene to think about. Whereas all the others contribute between 1% to 2% really in the hereditary breast cancer space. And right at the bottom, just want to draw your attention to the fact that despite all the advances in genomic and genetic testing and our knowledge about, penetrance and disease-specific risks, there is still a large volume of these families where the familial risk remains, although quantified, cannot be attributed to a single gene variant. So this is what when patients ask us as clinicians, what their risks are, I think I usually have this at the back of my mind because it helps to explain and contextualize how their risk might be placed in compared to the general population. At the top, you'll see that the pie chart there that's labeled A, actually most women, so almost 95% of women reporting breast cancer, particularly in older years, are developing it due to age-related changes. There might be some environmental and lifestyle influences there as well. But actually, the vast majority of breast cancer is still what we call sporadic breast cancer or age-related breast cancer. So actually, familial breast cancer is only found in 5 to 7% of the population. And if you dissect that down, that 5 to 7%, you get to the bottom pie chart, which tells you the split or contribution of gene-specific familial risk there, which we've looked at the other slide. And you'll see that the high susceptibility genes are still, by and large, BRCA1 and BRCA2 contributing to up to 25% of that. And then there's a larger chunk of these moderate susceptibility genes now, between 5 and 10% contributing to that, which again can be further sort of stratified based on the family history, and I'll give you an example of that as well. But before we do that, I thought it might be helpful to just do some revision about what the BRCA risks are. So this is 2017 data from the Embrace group and Kuchenbacher's group, which actually I'm really proud to say our clinic at Guy's has contributed the largest number of women to. And you'll see that for carriers of BRCA1, a germline pathogenic variant, the lifetime risk of developing breast cancer is up to about 70%. And they also have about a 40% lifetime risk of developing ovarian cancer. The male breast cancer, pancreatic cancer, and prostate cancer risks are actually not significantly elevated above that of the general population. But drawing your attention to the third table right at the bottom of the slide, and this is where some of your discussions might lead you today, is, these women also have a risk of developing a second primary breast cancer, a contralateral breast cancer. And you'll see that that risk varies depending on how long it's been since their initial breast cancer diagnosis. And this is important, particularly as you take them through that decision making around the timing of them choosing, contralateral risk reducing mastectomy and reconstruction. But actually, that the totality of that risk is still significantly elevated. So you're looking at between a 50-60% risk of them developing a second primary breast cancer. Similarly, for the BRCA2 population, you'll see that contralateral risk in the bottom table remains quite high. So again, up to 65% really. And the difference in the BRCA2 space is that although the lifetime risk of breast cancer on the top table is again about 70%, like the BRCA1 women, their ovarian cancer risk is lower, so it's about 20% in contrast to BRCA1, which was 40%. Here, the BRCA2 families also have, the men with BRCA2 pathogenic variants have an increased risk of developing male breast cancer and prostate cancer as well. So that needs to be factored into the genetic counselling that So I mentioned previously in 2014, a further gene, PALB2, was discovered, and it's taken us some time to establish the sort of gene-specific risks for this, but now that we're increasingly doing more testing, we have that data now, and you can see that, again, the risk for these women of developing breast cancer is reaching in some families as high as the BRCA families, although in other families it might be lower. And there's a reason for that, really, and I think it's in this next slide here. And you can see with PALB2, the lifetime risk of developing female breast cancer is actually hugely influenced by whether that lady has a family history of breast cancer. So you'll see that the blue curve here is a lady who you test. She's got a PALB2 pathogenic variant or mutation, but actually she doesn't report a family history of breast cancer in her wider family. And her lifetime risk hits between sort of, about 50%. But in contrast to that, look at this lady here with the sort of orange-red curve. And she reports that she's got, two family members with breast cancer in their 50s, and you'll see that her lifetime risk of developing breast cancer is much higher than the lady with the blue curve. And this is just showing us the influence that family history can have, despite the fact that two women might have the same pathogenic variant in the same gene. And these are the subtleties of genetic counselling, particularly when you're making those choices around contralateral risk reduction. So what are some of the strategies used for this group? Well, we've got surveillance through mammography and breast MRI. We've got surgery through bilateral mastectomy with or without reconstruction, but also to address the ovarian cancer risk due to the lack of evidence-based ovarian screening. We have a discussion with them about bilateral salpingo-oophorectomy for risk reduction, of course, once their families are completed. And then there's also a place for chemoprevention through the use of tamoxifen and selective estrogen receptor modulators. Here in the UK, we have an organisation called NICE, which gives us evidence-based guidance, and the familial breast cancer guidance is what sort of almost dictates how we look after these families and where we look after them, whether that's the GP in primary care or whether they're looked after in secondary care or in clinical genetics. But by and large, you'll see the risks sort of stratifies them in largely 3 groups, and I'll tell you about a 4th group in the next slide. And depending on the lifetime risk, they would be eligible for various levels of surveillance through mammograms predominantly. If you're at near population risk, women get 3 yearly mammography from the age of 47 now. And if you have a little bit more of a risk than most women in the general population, like if maybe you have a first-degree relative with breast cancer over the age of 50, you might fit the moderate risk group where your mammography is starting 7 years earlier to other women. If you carry a high-risk gene, some of the genes that we've talked about, you'd start to your lifetime risk would start to creep into the high-risk category where you would have a 30% or higher lifetime risk, and therefore that would warrant surveillance much earlier, probably from the age of 30, really. We know that breast cancer surveillance has the potential to both detect, diagnose, and treat cancers when they're small and less aggressive. We also now have a 4th category, as I said, that is run nationally, and it's called the very high risk category, where we know individuals have 40% or higher lifetime risk of breast cancer. So you're looking at a group, potentially a smaller group, but a distinct group of women who carry pathogenic variants and have a family history and are hitting that level of risk that warrant possibly MRIs between the age of 25 and 30 in some cases, and that carries on really for most of their life. So just thinking about risk-reducing mastectomy, because I'm conscious that's the aim of today's webinar. It's an option offered nationally here in the UK for any patient that is deemed at 30% lifetime risk of breast cancer or more. It's really important that those discussions are held in an multidisciplinary setting involving colleagues from breast surgery, oncoplastics, genetics, oncology, clinical psychology, and also breast care nurse specialists, so that we are making a shared decision, a best fit plan for our patients. And the aim is really to reduce the breast cancer risk by about 90%. With we know that's an effective way of reducing their risk, should they like it, with an occult malignancy rate of less than 5% really found at surgery. So you're probably thinking, how do we go about assessing all this, and how do we go about reaching all these figures? Well, there are several ways, but I'm just going to highlight one sort of tool that is becoming increasingly popular, certainly here in the UK, called CanRisk. This is a screenshot from the CanRisk platform. It is certainly not something that you can do in seconds. It has a lot of questions. You will need to fill in a lot of the phenotype of the patient, including their height, weight, history around, whether they've taken any oral contraception, hormone replacement, and it eventually has the potential to calculate for you their remaining risk of developing breast cancer over the next 5 to 10 years. Gives you an output indicating the lifetime risk, but also a 10-year risk, which can be really helpful when women are trying to make choices. What it doesn't have the potential to do is to give you the risk of a 3rd primary breast cancer, and we're seeing that increasingly in some of these carrier women. But with a note of caution that any tool doesn't replace clinical acumen. And I just wanted to show you this, just an output from one of my ladies from last week. And you can see that the arrow, so she's a 27-year-old, but her mum and grandmother both reported to have breast cancer. And we've actually found now a BRCA2 pathogenic variant or mutation in her mother. But when I put her risk through the CanRisk tool, you can see that it tells you that her ovarian cancer risk lifetime is 8.3%. I now know she carries a BRCA2 mutation, so it's hugely underestimating her ovarian risk, because I know that her ovarian risk would be about 20%. So it's just to give you a very quick example of how tools are still not good enough for us to replace sort of what our clinical acumen is. So lots of things to think about when we're thinking about risk-reducing mastectomy. There is no right or wrong decision. As I said, it's more about the best fit decision. We need to think about the age of the patient, but also things like, what their prognosis is, what are the competing risks that we're looking at? Is their chance of recurrence much higher than the risk of them developing a 2nd primary at the present time? And, would it be better for them to perhaps wait to make that contralateral decision later, or actually they're going to make that decision at some point anyway, so why not opt for it in the current treatment plan? But also things like whether they're on adjuvant treatment at the moment and what their comorbidities are. And lastly, risk perception. So no two women or no two individuals will feel the same about a particular figure or level of risk. And this is hugely influenced by things like their own family experience, their own history, and how things have gone for them, their personality type, but also their stage in life. These are often young women who haven't yet completed their family sometimes. Any recent triggers, losses such as early deaths in the family from cancer. And it's really important to just explore that with them as they're making these decisions. It's not always just about the figures in front of them and risk. Thank you.
That's a great talk, Rishika, and it's a great overview of all the genetics of breast cancer. And before we go to Rachel's talk, Ricardo is with us today. So if anybody wants to join on the Spanish channel, because we have more than 500 people now online. So if you want to join the Spanish channel, please just click on the globe and choose Spanish. And Ash, Andrew and Jill, I know, and Cicero, because you've just joined, if you also press on the globe in the bottom of the screen and press on the English channel so that Ricardo can hear you all fine. I'll be sharing some links for an in-person course that we're running here in Aberdeen, so please have a look at that. And now we have Rachel O'Connell going to talk to us about risk-reducing mastectomy, and Rachel is one of the consultants in the Royal Marsden in London. So Rachel, the next 15 minutes are yours. Thank you.
Thank you. Thanks very much, Ethan, for inviting me to talk today, and thanks to everybody who's participating and joining this webinar. So today I'm going to talk about risk reduction mastectomy. These are my disclosures, and I'm going to be talking about rates of risk reduction, who should have it, is it effective, and how to do it. So this slide you're probably familiar with. It looks at the rates of mastectomy, and this is from 1995 to 2005. And you can see here in the top graph, in America, the rates of bilateral prophylactic mastectomy have been creeping up. The contralateral prophylactic mastectomy rates have gone up significantly more, and Jill will be talking about that, and I'm looking forward to hearing her opinion on that. And therapeutic mastectomy rates have been going down slightly. So as we're doing more genetic testing, I'm sure those rates of prophylactic bilateral mastectomy are going up and have been doing so since 2005. This is a study from the UK published in the BMJ Open, and you can see here that the table looks at patients who do not have a diagnosis of breast cancer who've had a bilateral mastectomy from 2002 to 2011, and you can see here the number of patients undergoing this surgery has been increasing, much like in the States. Of course, there was also the Angelina Jolie effect. I'm sure a lot of us who've worked in breast surgery services are familiar with this, that around 2013, Angelina Jolie publicly disclosed that she had bilateral risk reduction surgery. And after that, we saw a sharp increase in the number of patients coming to the one-stop clinics, inquiring about risk reduction surgery, and indeed the number of patients undergoing this surgery increased. And this graph comes from a study from the States. As well as this, the similar data was reported by Evans and et al. In the UK. So I'm not going to talk too much about the genetics because we've really covered that with Vishaka's talk, which was really enjoyable and excellent. So thanks for that. As well as genetic factors, of course, family history, and then non-genetic risk factors such as mantle radiation. So these are usually young women who have undergone lymphoma treatment, and part of that has involved radiotherapy. These are the patients that can often be diagnosed with an increased risk of breast cancer, such that risk reduction surgery may be considered. Calculating risk, well, Vishaka has already talked about that, and I think this really has to be done in a multidisciplinary fashion, led by the genetics team. There are multiple different programs that can be used to calculate risk, and Vishaka talked about CAN risk, and these programs use different information depending on the information you have available and which tool you use. Things like genetic information, family history, but other factors such as patients previously having benign biopsies and breast density can also be included. Vishaka also talked about this. So in the NHS, we have NICE guidelines, and we consider patients for risk reduction surgery or discussion about that if they have a high risk of breast cancer, and that's a 30% or greater lifetime risk. So my first question is, does risk reduction surgery actually reduce the risk of breast cancer? Well, as you can imagine, there aren't any randomized control studies to look at this, but data retrospectively and prospectively has shown that we can reduce the risk of developing a breast cancer in those patients that are high risk by approximately 90 to 100%. But of course, it's critical that meticulous surgical technique is used to remove as much breast tissue as possible. And of course, it's important that if you're doing risk reduction surgery with immediate breast reconstruction, that this is done meticulously so that you maintain the blood supply to the skin and also remove as much breast tissue as possible. This table too comes from the American Society of Breast Surgery consensus guidelines. And this was a table showing several studies here comparing patients that have undergone bilateral prophylactic mastectomy and those that haven't in a high-risk group. You can see here that BCD is breast cancer diagnosis, and it was significantly lower in those patients that had undergone bilateral prophylactic mastectomy. So we can say that that undergoing this surgery certainly does reduce the risk of breast cancer. This is a study that I wrote up, which is Gerald Gui, who's one of the pioneers of risk reduction surgery in the UK, with obviously Professor Beldam as well, who's on the call. And in Gerald's data, we had 93 women who we followed up for 10 years. These patients all had immediate breast reconstruction, and at 10 years median follow-up, there were no cases of breast cancer. But does bilateral risk reduction mastectomy confer a survival benefit? And this is a bit more tricky. Once again, there's no randomized control trials, but the Cochrane group did a analysis looking at retrospective and prospective data. We know that breast cancer mortality is low and lifespan is long, so it's quite difficult to identify a large number of patients who have died to demonstrate that benefit, but it does indicate that survival benefit is seen in high-risk patients, particularly those with a BRCA1 or BRCA2 mutation. This study here looked at patients who underwent surveillance versus risk reduction mastectomy and looked specifically at breast cancer deaths. And they divided the group into those with a BRCA1 and a BRCA2 mutation carrier. And you can see here with the Kaplan-Meier survival curves, there is a benefit, particularly for those patients who are diagnosed with a BRCA1 mutation. And of course, we know that BRCA1 mutations are more associated with triple negative breast cancers, which have a worse prognosis compared to other types of breast cancer. And that I think that's why you see that bigger benefit for BRCA1 patients. So when to do the surgery, and I think Vishaka talked about this, it's a really important discussion and it involves shared decision making. It's important to consider the average age of when patients might develop a breast cancer. As well as that, it's important to consider the age at diagnosis of family members. A 5-year risk calculation can be done for patients really to understand what their risk is in the next 5 years, as that can help patients decide when the surgery might be best for them. But of course, there's lots of other factors to consider. Patients may wish to breastfeed and therefore delay surgery until they've completed their family. Women can be in the start of a new relationship and marriage, and perhaps it's not the right time for them. And then other patients may wish to prioritise their ovarian cancer risk reduction surgery, particularly if they come from a family where there's multiple number of patients who've had ovarian cancer. So at the Royal Marsden, we have quite a big population that we serve for risk reduction surgery, and we have a protocol for patients going through this. For once patients have been diagnosed with a genetic mutation or they have a family history that is thought to give them a lifetime risk of more than 30%, they'll meet a breast surgeon. We talk about all the different options of surgery, including simple mastectomy, implant-based reconstruction, autologous reconstruction, and then, of course, no surgery, so high-risk surveillance and chemo prevention. After that, patients will have a meeting with a psychological support team. This is often a one-on-one session or can be a group session. And during the pandemic, a lot of this was on hold, but when patients did have this session, it was done as a Teams or a Zoom session. As well as this, they'll have a discussion with the breast care nurses, talking about some of the practicalities, about how they think they'll feel afterwards, the practicalities of looking after children after this sort of surgery, you know, the recovery time, what to expect. And then we also have a checklist where we took the breast care nurses go through to make sure that they've had adequate discussions regarding some of the potential side effects and complications, things like sensation to the chest wall and nipple area, infection risk and necrosis. For implant-based reconstruction, of course, we always discuss breast implant-associated anaplastic large cell lymphoma, and of course, implant loss. Implant loss can be devastating for any patient who you have to go through, and also extremely stressful for the surgeon, as I'm sure many of you will be aware. And when we look at the IBRA data, we know that implant loss is not insignificant, and we need to, as much as possible, prepare our patients that this may occur. It's also important that patients have up-to-date preoperative imaging, whether that's an MRI or a mammogram, particularly over COVID times, because a lot of this imaging was delayed. So some patients went for quite a period of time without having imaging. Nipple preservation. Now, traditionally, patients would have a skin-sparing mastectomy with nipple excision. However, more recently, it has been established that nipple preservation is oncologically safe. And these photographs come from Gerald's paper. And then the top panel of photographs, A and B, this is a patient who's had nipple-preserving skin-sparing mastectomies. And then in the lower panel, this patient has had skin-sparing mastectomy and then later on gone on to have an implant, tattoo and nipple reconstruction. It's important to discuss the risk of nipple necrosis and asymmetry if you preserve the nipples, and also that the sensation will likely be diminished to a greater or lesser extent. But we do know that oncologically it's safe to preserve the nipple areolar complex. This study here came from the team at the Memorial Sloan Kettering and was published in the British Journal of Surgery. And you can see here in this table the number of patients undergoing prophylactic nipple-sparing mastectomy has been rising, really from about 2005 onwards. However, it is important to note the potential complications. And in this study of 384 breasts, so that's 192 patients, there were 6 patients who had to undergo nipple excision. 3 of them was because they identified DCIS, and 3 was for necrosis. There was a time when patients who were undergoing this surgery may have undergone a sentinel lymph node biopsy. This we know now is not necessary, as imaging modalities are significantly improved, and the chances of finding occult disease in patients undergoing risk reduction mastectomy is low. And from the team in the paper in the previous slide from MSK, they had 384 patients, and the risk of identifying an occult invasive disease was 0.8%. And in another paper looking at 115 patients that underwent bilateral mastectomy, albeit the majority in this study had contralateral prophylactic mastectomy, the risk of developing an occult, finding an occult malignancy was about 8%, but most of those, 6 out of the 8 patients had DCIS. Patient satisfaction is really important to have knowledge about and share with our patients. And I think it's fantastic that now more and more research is focusing on patient satisfaction. And this study here was a systematic review of patient satisfaction after bilateral risk reduction mastectomy. And you can see here that satisfaction levels were high, but the areas that were lowest were sexual well-being and sensation. So again, I think it's important to discuss these with patients when you're preparing them for surgery. So in conclusion, we know that bilateral risk reduction mastectomy in a population with a high risk of breast cancer is effective in reducing the risk of developing a breast cancer. But I believe it is absolutely critical that we do this as a multidisciplinary team, not as a single surgeon, involving genetics, plastic surgery, particularly if you're talking about autologous reconstruction, breast care nurses and psychological support to help prepare the patients and some of the practicalities of undergoing surgery. It's critical that we discuss with patient the side effects of surgery, the complications, discuss with them the satisfaction, sexual health and sensation afterwards, have up-to-date imaging, and there's no need for a patient to have a sentinel lymph node biopsy when they're having this sort of surgery. Thank you very much.
That's a great talk, Rachel, up to the point and within time. So that was lovely. And Ricardo, you have a little fan club in the chat. We're just all talking about you. I know. Now, the next speaker is Jill Dietz from the States, and Jill was the previous president of the American Society of Breast Surgeons. And she's going to give a lovely talk about risk-reducing, the contralateral risk-reducing mastectomy. Jill has sent me kindly her recorded talk, which I'm going to play now. Thank you, Jill. So.
I'd like to thank the organizing committee for inviting me to come in and speak with you today about contralateral prophylactic mastectomy. And none of my disclosures are relevant for this topic. So back in 1998, U.S. Women's Health and Cancer Rights Act was passed into law. And it dictated that women going through breast cancer treatment had access and had paid for reconstruction, any procedure to create symmetry, prosthetics, and any complication resulting from the breast cancer treatment. We saw huge rises in the contralateral prophylactic mastectomy rates in all age groups, in all histologies, all insurances, all income levels, and all facilities, with the most dramatic increase being in young Caucasian women that are high income or access to really good health care. Even more recent studies, despite the fact that our society put out guidelines helping surgeons talk to patients about CPM, we are still seeing rises in the contralateral prophylactic mastectomy rate. Also, these increases are being seen in other countries, such as Canada. This study showed a 6-fold rise in the rate, and again, in the same cohort of patients that are younger and with a higher income. In other areas of the world, the data is sparse, but in these two studies in Switzerland and Italy, we didn't see elevating CPM rates, but increasing reconstruction rates. However, in UK and Romania, these two studies showed that CPM rates were on the rise. Why is this? Well, in the United States, one of the reasons why is because it is paid for by the law. Physicians are actually incentivized with our fee-for-service healthcare structure to do more surgery. Also, surgeons' opinion about CPM is much more prevalent in our country, and surgeons respect the patient's choice if they want to do it for whatever reason. There's also better surgical techniques such as nipple sparing, direct to implant, nerve preservation, And the studies we all know show that if you have an MRI, whether that finding is a true or false positive, that increases mastectomy rates. We've seen increases in genetic testing. And what about blogging? Women can look anywhere on the internet and see that somebody's breast cancer came back in the other breast. There's also studies showing that women have an increased sense of what their personal risk actually is. And then, of course, celebrities such as Angelina Jolie, very public with her bilateral mastectomy for her BRCA gene mutation. Now, we've seen that in the United States, there's huge variations in the rates of CPM within the Midwest, seeing almost as much as 50% rates for women with young women with small urinary cancers. So is this culture or access to care or surgeon opinion? It's hard to say. We do know this study looked at different specialties of physicians caring for breast cancer patients, and they have varying comfort levels with recommending CPM. Certainly plastic surgeons are the colleagues that feel most strongly, that CPM is most strongly indicated than other specialties, for instance, such as medical oncology. The study here looked at the physician's knowledge about contralateral breast cancer risk and their likelihood to recommend a contralateral prophylactic mastectomy, and showed that those physicians who had low knowledge about risk were actually more likely to recommend a CPM. In this study, showed what we probably know, and that is in those women who've had a contralateral prophylactic mastectomy, they have higher reconstruction rates, but they also have about twice the complication rate. They have more additional procedures and therefore higher costs. And if you do adjust for those breast reconstruction and additional procedures, the costs are actually quite similar. But we know that these CPM rates are too high, cause extra complications, additional operations, higher costs, and we didn't even get into satisfaction. But who should we recommend to have contralateral prophylactic mastectomy? Well, we know that BRCA patients have a very high risk of developing a contralateral breast cancer, as shown in this meta-analysis. We also know that for women that have a CPM and they are BRCA positive and young and have early breast cancer, this particular study anyway shows almost a 50% reduction in breast cancer specific mortality. And then we know women who have had Hodgkin's disease, especially at a young age, have a significant increase in developing breast cancer in both breasts and a high rate of a contralateral breast cancer. Those non-BRCA genes seem to rely mostly on family history. So those with those gene mutations in a family history are also at increased risk. So back in 2016, the American Society of Breast Surgeons got together and formed a consensus statement around the data, outcomes, and risks of contralateral prophylactic mastectomy. And those that should be considered at significant risk of a contralateral breast cancer are those BRCA carriers, those with a strong family history that haven't had genetic testing, and those with mantle radiation. And CPM can be considered for those at lower risk if they're gene carriers, particularly with a strong family history, or those with a strong family history, but the patient's negative and we don't know about if the family has a gene mutation. Then CPM may be considered in other situations, like to limit surveillance in women who have very dense breasts, or they keep getting called back, or to improve symmetry in a reconstructed breast, to manage risk aversion or extreme anxiety, although this is much better managed through psychological support. And then finally, it should be discouraged in the average risk woman with unilateral breast cancer. those with advanced cancers or very high risk for a surgical complication, or if the woman has tested negative for a BRCA mutation and her family is positive, and in male breast cancer. In addition, the ASBRS also additionally made a decision-making tool and published that to help surgeons talk about different talking points related to contralateral prophylactic mastectomy, which can be very useful. Things like, you know, it's not 100% protective against having a cancer form in your other breast. It's not going to improve your cure rate for your known cancer. It won't reduce your risk of your cancer returning from your known cancer. You know, all of those talking points that you need to discuss with your patient to do shared decision making. This is a really nice paper that was just really recently published. And they actually recommend, obviously, going over the risk-benefit profile in a personalized fashion. But they also recommend delaying decisions until the treatment of the primary cancer is complete, offering that psychological and surgical counseling. And they do recommend that CPM should be reimbursed in every country as long as the multidisciplinary tumor board considers it a reasonable option, and that these patients really should be treated in a specialized breast unit. So clearly, it's going to take a combined approach. Physicians need to be educated. The data supports that not all physicians have a good understanding of what the patient's contralateral breast cancer risk really is. And because physicians play such an important role in the decision-making process, this is somewhere that really needs to be, the education needs to be beefed up. Also, care teams need to be encouraged to use these available shared decision-making tools, and maybe we should be educating directly to women themselves. But if you want to make the biggest impact in reducing the rates of contralateral prophylactic mastectomy, you really need to change the incentive structure. Because right now, most of everything that we've already talked about has been tried, and we're still seeing very high rates. So join with me in getting the word out there, and I hope everybody has a great day. Thank you.
That was a great talk, Jill, and thanks for sharing that. And we have the last speaker, last but not least, is the lovely Cicero Urban. And Cicero is one of the serial offenders also on those webinars, and it's always great to see Cicero online. And Cicero is going to talk to us about ethical consideration and risk-reducing surgery. I'm really looking forward for this talk also, Cicero. The next 15 minutes are all yours.
Thank you so much for this invitation. It's a pleasure to be with you. And I think that my topic maybe is more complex than the basis for the other ones, because this is the more practical ones in terms of practice, in terms of reducing the unnecessary mastectomy. Ethical considerations in risk reduction surgery. I don't have conflict of interest here to disclaim. And why are there so many unnecessary mastectomy to reduce risk? This is an important question to answer here. The second one is, sorry, it's not working.
It's working all okay, Cicero.
Okay, and when are they really necessary is the second question. I like this answer here. Drastic surgical solutions have become a socially acceptable and even glamorous approach, but it's not enough. Is this the Angelina Jolie effect? Only to this? And the answer is no, not the only explanation to this phenomenon. I think that the explanation to this phenomenon is the Mencken effect. Mencken was a journalist in the 20th century who said that for every complex problem, there is a clear, simple, and wrong answer. Well, my presentation is divided in 3 different topics. The first one is ethics before technique, because ethics here in this topic is more important than technique in terms of discussion, in terms of practice. I will show you how to use a very practical clinical ethics decision model in your practice that can help you in your practice. And the third one, the second one is the most interesting thing. That one is just a reflection, a philosophical reflection about the times that we are living, a controversial choices in a controversial world, and some good news in this topic. Well, ethics before technique. What is ethics? Is it the best way to do something? Is it the right way to do something? Or both? To me, it's both. The last one is the classical definition of ethics, but I will not discuss in this point. What is the best for the patient? What is the best for the system? And what is the best for the surgeon? The 3 questions that we should answer when we have this complex situation in front of us. In an ideal world, you should have a convergence of these values. The best for the patient should be the best for the system and should be the best for the surgeon. But in the real world, we have convergence and divergence of values in practice. And we see it every day. Why ethics matters? Well, besides the numbers of risk reduction, prevention of deaths, and techniques, there are the patient's risks and more, the patient risk perception about breast cancer and the quality of life and autonomy. So we have more data we have more concerns about ethical points and not so miserable points like quality of life than with technical points in terms of the way we do the mastectomy, for example, or the reducing death, for example. Why in particular should risk reduction mastectomy be seen more as an ethical concern than as a strictly medical question? Of course, we are discussing medical questions here, which are important, and they are the basis for the ethical decision. But in practice, we have more ethical points to discuss with the patients than technical points. Technical points will help us to try to avoid unnecessary surgeries. Well, it is a risk condition, not a disease. We have patients here. We have patients that have risks, but not the disease. The cause of the risk is a familial, hereditary, genetic factor, and this is a term that I want you fix in your head. Genetic exceptionalism. This is very important, what we will discuss here. Breast is not a thyroid gland, aneurysm, or appendices that you can remove without consequences. Social and psychological consequences here are very high when a patient goes to mastectomy. And the assistance of ethics is always required for complex choices. Well, the second point, most important of how I will talk here, a very practical clinical ethical approach for risk reduction mastectomy that you can use in your clinical practice. Other than being an oncoplastic surgeon, I am a bioethical professor. Let's see this case. A young woman, 28 years old, deeply affected by her mother's death from breast cancer at the age of 30 years old. All genetic tests were negative. After concealing an explanation, she still wants risk reduction mastectomy. What did you do on her case? And what if she has breast cancer? It changed your decision or not? Well, I invited you to go to this great book, Clinical Ethics, a practical approach to ethical decision in clinical medicine. This is fantastic. It helps us to understand the things and to collecting, sorting, ordering the facts in a clinical ethical problem. 4 points, just 4 points. Medical indications, preferences of patients, quality of life, and contextual factors. It will help us to clarify our decisions in practice. And in this case, it is fantastic. Medical indications. Medical indications is very clear to us. It's the facts, interpretations about patients' physical and psychological conditions that provide us a reasonable basis for the decision, for the judgment. This is clear to us. And we have lots of data. You saw here today, lots of data in the indications of risk reduction mastectomy, of contralateral mastectomies, and risk reduction mastectomies, and so on. Well, we know about BRCA1 and BRCA2, the cumulative risk that is higher in this kind of patients is very high in BRCA1, maybe higher than BRCA2. We know that mutation in these patients in BRCA1 is more frequent to have triple negative, more aggressive tumors. We know that we have, for example, in terms of survival, we have, for BRCA1 positive patients, we have better results than in BRCA2. Maybe BRCA2, we don't have good results or similar results to BRCA1 in terms of survival when we do risk reduction mastectomy. And we know that it was one of the questions in the chat. PALB2 mutation is associated with 35 to 16% of increased risk of breast cancer. ATM CHEK2 mutation risk 25 to 30%. So it's necessary to these cases out of BRCA1 and BRCA2, which are more clear to us, individualize and a multidisciplinary approach. So that's the answer to the question in the chat. It's necessary to do an radiogram and to see how is the family history of this patient. Well, we know that contralateral mastectomy, we have more complications. We know that we have more complications and sometimes delayed initiation of adjuvant therapy, and so we can have a prejudice. We can have some problems in terms of adjuvant therapy in patients who undergo contralateral prophylactic mastectomy. We know that subpectoral has less complications than pre-pack when we do prophylactic mastectomies, and the overall complications in bilateral surgeries are higher than unilateral. So in terms of indications, it is more clear to us about technical points. And we know that doing a good treatment, we can reduce the risk of contralateral breast cancer. So this is indications. These are technical points. In women who have breast cancer in one breast, removal of the other breast may reduce the incidence of cancer in that other breast, but there is insufficient evidence that this improves survival because of the continued risk of recurrence or metastasis of the original cancer. Well, second point, preferences of the patients. The choices that persons make when they are faced with decisions about health and medical treatment. This is the issue of autonomy. This is fantastic. This is the most important point in terms of ethical decisions. In general, all persons have a fundamental right to control their own body. Well, think about it. We see the world not as it is, but as we are. Well, autonomy. Autonomy may be said that autonomy is the worst paradigm of decision-making, except for all the others. Although we live in primacy of autonomy in our society, it should not be an absolute value. It has limits and carrier responsibilities. This is very important. And what about most high-risk patients in the world does not have access to genetic counsel and breast reconstruction? And this is a reality in Brazil too. We have two different kinds of Brazils. We have a Brazil our patients have the right to have everything and do and have all the best. And the other Brazil, that the patients don't have access to genetic counseling and to the best of breast reconstruction. Look, very important. Words have power. To prevent, for example, in the Merriam-Webster dictionary means to keep from happening. Should we talk about prophylactic or preventive mastectomy? Neither one, please. It is not prophylactic mastectomy. It is a risk reduction mastectomy. Protection is not absolute, and we are not sure neither that the disease will occur, nor that the intervention will always succeed in protection of that woman. Words have power. Risk reduction mastectomy is about mutilation. Mutilation in the dictionary is to cut or permanently destroy a limb or essential part. So mastectomy is a mutilation, even with breast reduction, because we know that it is not a normal breast, even when we achieve the best result in terms of reconstruction. Third point, so first indication, second preferences or autonomy, and the third quality of life. Well, the risks of genomic tests are psychosocial rather than medical ones. Genetics exceptionalism. Efficacy is high, but not absolute. There is a critical balance between the risk of local complications and the level of protection. Even screening, it is not a prevention. It reduces the risk of dying from the disease. And here, most important point, a risk condition is not a disease. We are talking about reducing risks and complications, and it's necessary to balance complications and the risk reduction. Well, some severe diseases, genetic diseases, are caused by a single gene, for example, Huntington's disease, but they are not the rule. Most of the genes that cause some disease they have incomplete penetrance or variable expressivity. Most common conditions like breast cancer are polygenic. And this point is a critical point in ethical discussion. People tend to overestimate the impact of genes. So if you have, for example, a patient with a VUS mutation, she tends to think that maybe this in the future will be something that I need to carry out. Well, in addition, some US studies mention that between 30 to 40% of women with breast cancer consider contralateral breast mastectomy. Higher levels of anxiety and fears of cancer, worse body image before surgery. Contralateral mastectomy was associated with more body image distress. Quality of life was similar, but we have lots of problems when the patient goes to mastectomy because patients are less satisfied with cosmetic results, body image and sexuality. And this is necessary to put in the pocket to the patient before to understand that maybe my contralateral mastectomy or bilateral mastectomy is the better to them. Fourth point. So, medical indications, autonomy, quality of life, and contextual factors. Here, this point addresses ways in which professional, family, religious, financial, legal, and institutional factors influence clinical decisions. Choices by the autonomous agents, doctor and patients, are influenced by constrained by the context in which they take place. This is very important, and sometimes we don't think about it. We don't know how to figure it out, these points. Psychological and cultural factors. Two agents, two patients with the same risk assessment have huge differences in their risk perception. This is very interesting. How risk communication is done most of times is not neutral. And how is the perception of the patients vary according to different social cultural environments. Our society, think about it, our society is risk adverse and control prone. That's because we have lots of patients trying to go to this kind of surgery. Quantitative factors are important, but some qualitative are more relevant. Genetic risks are small, invisible, and not under control. It's different from smoking, for example, which could be in my control. Characteristics like these usually increase the anxious perception of risk factor, and presence of children impacts the decisions, for example, to go to bilateral mastectomies. Who is doing risk reduction mastectomy? BRCA mutation, of course, is very important. Family history of first and second degree relatives who died from breast cancer. These patients tend to go to, like the patient that I present you, 20-year-old, but a mother died with 35 years old. And age and childbirth also influencing the decision. Well, contralateral prophylactic mastectomy has additional costs to the system. So we should try to converge the decision to the best of the patient, best to the system, best to the surgeon. Besides age, another thing that related to us as oncoplastic surgeons, immediate breast reconstruction is the most important factor in contralateral mastectomy. This paper you should read. You, for example, that works in America, where you try to respect more the autonomy of the patients than the decision of the doctors in some aspects. If it is mainly the decision of the patients, we will have more contralateral mastectomies. If you try to go to the doctor's decision, we will reduce the risks of unnecessary contralateral mastectomies. Well, the third point, controversial choices in a controversial world and some good news. Controversial points. It was presented already here. I disagree with this. Dense breast surveillance has failed, surveillance fatigue, improved symmetry in reconstructed breast. This is not the rule, but something that it's very rare in practice to manage the risk aversion and to manage extreme anxiety. It's best to achieve it through psychological support strategies, not surgery. We are not psychiatrists and we are not psychological ones. And some good ones, good news. We are, in fact, it is good, reducing unnecessary surgeries. This is good. We have guidelines, very strong guidelines, saying that it's not necessary to do contralateral mastectomies in patients that don't have high risk. And we should follow them. Read, follow them, send to the patients, and discuss it. And the Angelina Jolie effect is reducing too. This is good. She's not the guilty. The guilty is Mencken, the journalist, because to try to find easy answer to complex problems, it's not the way. It's not the way that we should do. Well, who in fact should do in ethical and technical points are hereditary breast cancer, BRCA1, the most important of them, selected cases of familial breast cancers, chest wall radiation therapy, and some carriers, but for it's necessary to do an individualization of these cases. For example, CHEK2, PALB2, P53, CDHY. And my final message to you, The impact of availability improving the quality of reconstruction and increasing the indications of unnecessary mastectomy, however, has not been studied, but we know that, of course, it raises the indications of a prophylactic mastectomy, contralateral or bilateral, because patients, at least in Brazil, they think that it is okay, we will just change the breasts for augmentation mammoplasty, and this is not true. Unfortunately, this is not true. Contralateral risk reduction mastectomy has complications and costs that may be higher than the expected positive effects. The indication must take into account the oncological, reconstructive, and psychological aspects, expectations of the patient. Sometimes the patient thinks that the breast will be the same, and maybe better, because she will put an implant, the breast will be in a better position, and so on. But in practice, this is not true. And consider in your practice to use the 4 boxes. Clinical ethics model can help you in the decision-making process, not only on risk reduction mastectomies. I use every day in my practice. And this is something that I want you to think. William Osers told that medicine is a science of uncertainty and an art of probability. I am not Osers, of course, but I think that risk reduction mastectomy is an indication of probability and an art of uncertainty. This is my team, my breast dream team in Brazil. I want to thank to them, and I want to thank to my family for all the support that they have. In fact, I have the first communion of my son. I had the first communion of my son today, and I have a big party today. But thanks to my great friend Yazam, I'm here with you.
Thank you, Cicero. I cannot thank you enough. I know that you have a family commitment today, and thank you very much for taking the time and for being with us. Now, shall we open all the cameras? So we have Andrew Beldam and Ash, and we have Vaishaka. So Vaishaka and Ash have been so busy on the question and answer section. They answered nearly everything. There's not much for us to discuss, which is great. And I've just shared the link for the in-person course in Aberdeen. So if you're interested, having a look at that, that will be in July. The cadaveric course is fully booked, but there is still some places in the lecture-based course. From the faculty, we have Alberto Rancati coming from Argentina. We have Ash, we have Andreas Karakatsanis coming from Uppsala. We have Giuseppe and Nicola coming from Italy, and we have quite a few people from the UK, like James Harvey, like Shelley Potter, Stuart McIntosh. Of course, Ricardo is always there. He's always part of the team. And we have Farid Mayboudi coming from Australia, among other people. So it will be great if you want to look at that course. Now we start the discussion. And each time I see Prof. Beldam, I hear a little story, because Prof. Beldam was one of the first to do risk-reducing surgery in the UK and the world. So do you want to share that story with us, Andrew?
Yeah, I will. Can you hear me?
We can hear you all fine.
So thank you very much. Yeah, let me just quickly flip to the family situation. I've got a brand new little grandson today. So I've left the celebration of that. He's very tiny. And yeah, it's great when you get older, you see these little family events happening. I find it impossible to think that it's 25 years since I did the first risk-reducing mastectomies in Manchester. I was one of the first surgeons in the UK to be dual trained in surgical oncology as well as in plastic and reconstructive breast surgery. And I didn't see any sense in keeping the two separate. So in my oncology practice, by 96, 97, I'd been a consultant for several years, and I was already doing a lot of reconstructive surgery, and I was doing immediate reconstructive surgery. And I worked and was very fortunate to work very closely with Gareth Evans, who has become a titan in genetics internationally. And he and I set up together a family history clinic that we worked in, and we had some very motivated, pioneering women who had come to the clinic, and we were calculating risk. We were doing BRCA1 and then later BRCA2 testing. A lot of these women, their own mothers had died from breast cancer in their 30s and in their 40s. And these women were highly motivated. And there were a small number of them who said, look, you're doing reconstructive surgery for women with cancer. Why can't you do what was then called prophylactic surgery and do immediate reconstruction for some of us? And my reaction was no. I thought it was unethical. I said there's absolutely no evidence that this is going to work. And I held off for a couple of years doing this. And eventually I got pushed into doing it by one of our clinic nurses who was from one of these families. And we found lobular carcinoma in situ in both her breasts. And immediately we began to think, well, maybe there's something worthwhile in this. And so in a very limited way, we started doing risk-reducing surgery. I think I was actually one of the first ever to say we should call this risk reduction, not prophylactic. And I did about 20. And then I presented the data to the Surgical Research Society in the UK and to BASO, the Association of Cancer Surgery. And I met a storm of opposition. A lot of people said this is completely unethical in the question time. And I had to sit back and think about this quite a lot more. And there actually are some quite important features that really need to be borne in mind on this. Now, I haven't prepared a talk for this evening, so I haven't got a lecture worked out, but I'm just telling you some of the touch points that I think are important. The first thing is that a breast in which every single cell contains a BRCA1 or a BRCA2 variant is not a normal breast. It may look normal, but on a molecular level, it is far from normal. And that is the first thing. I never, ever advocated doing risk-reducing surgery for a woman with a normal breast. The second is this question of the word mutilation. Now, the word mutilation means to destroy. It means to disfigure. It means to mar. It means to make look terrible. And one of the things we did was to make sure that as far as possible with the reconstructive surgery that we were offering, these people were not going to look mutilated. They were not going to look as if they had had part of themselves destroyed. Furthermore, if we were doing this operation in an attempt to give them a natural lifespan, not shortened by breast cancer, we need to leave them functionally and aesthetically as perfect as possible. And so that was the next point to make. And that is why we put together a very dedicated team, and myself and one of my colleagues were the only two in our whole region who were doing this type of surgery. But we produced a lot of animosity, and a professor of breast surgery in London wrote an article in the British Medical Journal in 1997 or 98, and the title was Prophylactic Mastectomy, Deliverance or Delusion. And in that article, he wrote, prophylactic mastectomy is a barbaric procedure which seldom, if ever, should be performed. I sought legal advice because it was very clear which department he was talking about. And the advice that I was given was carry on doing what you're doing, but keep all the data. Keep everything meticulously. recorded. Make sure the quality of what you're doing is very high, that everybody is followed up. And therefore, in 2000, Gareth Evans, myself, and Fiona Lalou published a protocol. And it was that protocol that said patients must have formal risk assessment, Gale model, and subsequently Tyrer-Cuzick, genetic testing offered, psychological intervention, a slow period to get the decision, not to do it in 6 months or 6 weeks, but to leave it to make sure the decision was absolutely right. And the aim was reduction of breast cancer diagnosis. The secondary aim was to diminish early breast cancer death, but to do so with a high quality of life and with low complications. And a couple of years ago, we published the 25-year data, in fact, 30-year data, long-term evaluation of women referred to a breast cancer family history clinic. We had over 4,000 women in this publication, of whom around 400 had risk-reducing surgery, and we had calculated the numbers who should have developed breast cancer, and it was 100, so 25% so far. With the data that we kept, we'd actually seen 4. So that's a 96% reduction rate in diagnosis so far. And of those 4 who did develop cancers, we've still got them. I still see some of them. We still follow them up. Not one of them has passed away. So it's true that when Angelina Jolie declared in 2013, there was a surge in referrals, but importantly, I don't think we operated on people who did not have risk. I left Manchester in 2011 and moved to Barts in London, and the figures in Manchester dipped after that. And then with Angelina Jolie, they came up again when that followed. And the paper we published with the red bars showed the Angelina Jolie effect. Now, I've said a lot, and I'm not going to say any more at the moment, except just to say, do not ever, ever confuse contralateral mastectomy in a woman who has been treated for cancer with a cohort of patients who have never had cancer and who want bilateral risk reduction. They are utterly and totally different. And yet most papers that have been published willingly confuse the two. They mix the data, they put tables on one line of the table, there's bilateral risk reduction, on the next line there's contralateral risk reduction. In my experience, I tell all my patients with cancers, a contralateral mastectomy will not influence their survival or their recurrence rate from their primary cancer. Overwhelmingly, they say to me, the reason I want contralateral surgery is because I never, ever want to go through all the diagnostics and primary treatment of breast cancer ever again. Now, interestingly, if you look at the data, and we've published some from Manchester, it's the BRCA carriers who, after 3 years with an early stage breast cancer, begin to get the benefit of contralateral in terms of survival. But it's a completely different picture compared to cold risk-reducing surgery. And I really don't think we should confuse the two at all. It's a very different position. And the different context is paramount in that. So of course, now it's a thoroughly well-established operation. It's one that is done almost routinely in most breast centers around the Western world, although interestingly, the culture can make a big difference. So for example, there are still very few risk-reducing operations performed in France and in the French-speaking world. And I don't quite understand that. I don't know enough about French culture to understand that, but that's an interesting geographical and social difference. I'll stop there. I've said a great deal, probably more than I'd intended to, but I think that just gives you a little. I personally now have done approaching 500 of the bilateral operations. I know what works. I know what doesn't. I know a great deal about immediate breast reconstruction as a result. And yeah.
That's great. That's great. I think we have Cicero's hand up. And then after that, Ash will be running lots of the questions and answers in this. So Cicero.
Very fast. Fantastic points, Sandra Waden. It's a privilege to see you personally. It's my first time, and I know all your publications and so. And just to add something in terms of, for example, cultural points. In Brazil, we have a plastic surgery culture in women. They think that that she will go to, for example, to a aesthetic surgery. Bilateral mastectomy is something like this: remove the breast and put an implant. And this is something that it's necessary to clarify the risks and maybe the positive points that this kind of surgery could have in this kind of patients. It's in France, for example, it's completely different. And I don't know in UK, but I think that it's necessary to understand what is your culture, local culture, in terms of. I have lots of patients that come to me and wanted to do bilateral mastectomy without risk, and this is a disaster. If I go to the autonomy and just do what the patient wants, I will do damage for the patient. So I love your points, and I totally agree with you.
That's great, Cicero, and great points. And there's a few people asking about lobular cancer, and lobular is a different cohort from today. But Ash, you wanted to lead on a few questions?
Thanks, Yazan. So great talks by everyone, obviously. Andy made some very good points. I think what the young surgeons need to understand is there's a difference between a contralateral prophylactic mastectomy in a patient who doesn't have high risk with a unilateral breast cancer as opposed to risk-reducing mastectomy. And that's a point very well made, Andy. And that's the point that we need to drive home, because the patients requesting a contralateral prophylactic mastectomy, which Jill spoke about, are patients with a unilateral breast cancer without any perceived higher risk of a contralateral breast cancer who are now requesting the other breast off for various reasons. So coming back to, in order of the talks, I think my first question goes to my colleague and friend, Vishaka, who I haven't seen for some time. So lovely to see you online, Vishaka. So it's a question that appeared online as well, and I've had for some time, is in patients with mutations, let's say a BRCA1 mutation, who have an index cancer in one of the breasts and complete chemotherapy, polychemotherapy, complete. We see that in sporadic cancers, there is a risk about 30% of contralateral breast cancers. Do we see that in BRCA carriers, and can we tell them that?
So in fact, I think in BRCA carriers, it's twofold to that, isn't it? So you see up to 65%, which is why actually all these discussions in this webinar is so important, because
so that's a great point.
Layer of complexity.
I think that's a great point. So if a patient wants to delay the contralateral mastectomy for family reasons, because she wants to have children, whatever it is, and she's had finished chemotherapy for the triple negative breast cancer, how long would you say is safe for her to wait?
I think that's probably a decision that we discuss in every clinic together, don't we, Ash? Because, and I put a slide up showing there's no right or wrong answer, and it's very much, we need to be led by that lady and the patient. We take a lot of time to break down their risk into sort of 5 to 10 years to give them a more specific individualized risk, so that they can see a little bit further in terms of what is the risk in the next 5 to 10 years of a second new primary occurring, and that features really highly in the way that we discuss that with them, because they may actually choose to wait for some time and carry on with surveillance, which is an equally appropriate option. So other women might, on the other hand, feel that that will raise their anxiety, and they may choose the contralateral risk reduction now. But I know that other women may choose it later, and both are actually quite reasonable options, I would say, as long as they are clinically informed and patient-led.
You made excellent points, and that ties into what Andy said. So,
Can I ask one thing, Ash?
sorry.
Can I ask one thing?
Yeah.
Yeah. So Vishaka, you shared the CanRisk online, and is that open for everybody to use?
Yeah, it is. It's free access. You just sign in, register, and you can use it. But as I said, there are lots of little nuances when you use CanRisk, and the output can really very quickly change if you don't input quite accurately. So there is a little bit of an art to that as well.
Because there is always very important to individualize the risk, because there is the absolute risk and there is the residual risk. So a risk of a BRCA1 that had breast cancer in her 30s, her residual risk is much higher than a BRCA1 that had hair cancer in her 60s. So it's very important to know that residual risk before deciding on the risk reduction. Does that make sense?
It does, yeah, absolutely. So we and that's why in clinic we sort of break it down and say, what's your age-related risk? Because exactly as you say, a 30-year-old versus a 60-year-old have a different proportion of hereditary risk, don't they, to live through, essentially.
Is there a number on that residual risk that you say it's reasonable to consider risk, contralateral risk reducing surgery if the residual risk is more than 20%, 30%? Is there something that had looked at benefit and risk from that point of view?
Yeah, so by and large, we say sort of if their risk is about 2% per annum, that warrants a discussion about risk reducing mastectomy.
That's great. That's great. That's all from my side. I'll keep my.
Right. I can see Andy's hand up, but just one point quickly. So what Yazan has shown and what Vishaka said in the last is what Andy has been saying, that managing these patients is not straightforward. BRCA patients require a specialist BRCA MDM, which we have it, guys, fortunately, with Vishaka and team. Andy, your point.
Yeah. Another quick story. As part of my training, I was at a plastic surgery unit in Nashville, Tennessee. And the surgeon, who was an internationally known reconstructive surgeon, was doing a contralateral mastectomy and reconstruction on a very young woman, and he was presenting the case to the theatre group, and he said, this is a young woman who had a grade 3 cancer. It was 9 positive nodes. It was 9 months ago. She'd had chemotherapy. Now we're doing the other side. Now, any questions? And I said, yeah, why are you doing this operation? And he said, well, this is a very strange question, isn't it? Anyway, he was not a surgical oncologist, so I gave the theatre team a small tutorial in oncology and metastatic disease and survival. And I said, 9 positive nodes 9 months ago, it's not really this breast that's going to threaten this woman's life expectancy, is it? And after that, there was a silence. And then the same surgeon said, well, I guess that's the wisest comment we've heard all morning. And I think that's what it is. It puts it in context. You're not going to do a contralateral on a woman who's got 9 positive nodes 9 months ago. You might consider doing it 5 or 6 years later when they'd remain disease-free. On the other hand, a BRCA carrier who's got a 6 millimeter grade 1 tumor, you might do it all at the same time. It's all to do with context.
And
Yazan and Cicero.
Yeah, to guide people, just because there's lots of people from different parts of the world. So there is some guidelines, like the NICE guidelines, that are available online from the UK, but many people also follow the NCCN guidelines, Jill. So is there lots of guidelines on, I think there's 2 or 3 different guidelines on risk reducing and on genetics, also on NCCN, that's available for free. Am I correct in saying that?
Cicero showed the slide, didn't you? Cicero showed a slide with the 3 guidelines.
That's right.
And they're open for anybody. Anybody can just access that from anywhere in the world. It's not, you don't need a special access to have those.
Andrew, why is the main question? Most important, and then how or when? Why is the first question when we should do something in terms of surgery? So I totally agree with you. And I'm surprised that the surgeon didn't thought about it.
Thanks, Cicero. So Rachel, great talk. I have no questions for you because you covered everything really so comprehensively. It's not because I don't want to ask you questions. It was a great talk, very comprehensive. So coming to Jill's talk, Jill is a bit nervous. I've been stalking her for the last 3 hours. We were on the breastics, then we were in the Estro meeting, and now we're together again. So I had to send her a text to say I'm not stalking her. So Jill, you made a great point about contralateral prophylactic mastectomies. You covered it really well, and thanks for that, because I'm debating you later this week, so I know exactly what to say now. But I think you made a great point, and Cicero said that as well. So where there is data that when surgeons actually advise against a contralateral prophylactic mastectomy, the uptake drops to about 6% when you compare it to surgeons who don't offer or who don't kind of refuse to do it. It goes up to about 57%. So that's a great reason for the surgeons to, like Cicero said, to underline the fact that there is no benefit and you might have problems and everything else. And Emanuela, who's been very active in asking questions online, and I said I'll ask this question. So this is again, this is let's say it's a philosophical question, and it comes to your moral, your ethical talk. So my problem is, when patients are very driven to have a contralateral prophylactic mastectomy, and that's the word, they're actually driven. It's almost like an obsessive personality. They're anxious. They believe in what that perception, that risk is going to be there. And they will, they might go to Andy, and Andy will say, I'm not going to do it. Then they'll come to me and I say, I won't do it. They'll come to you, you won't do it. Now, they might find a surgeon somewhere in the world who's ready to do it. And my question is always, my dilemma is always, should we do this within the confines of a good functional MDT where we can get a good psychological evaluation, we can do a good surgery, give a good results, or leave her out there to her own devices? I mean, it's a very difficult question to answer, but I'd love to know, Cicero, your views and then Andy's views on this.
Cicero, are you going to chime in, or did you want me to chime in?
Great, Jill, you can chime in. Cicero, I think,
okay.
Didn't hear the question.
I'll just say quickly first that I think we all as surgeons have a very significant responsibility to our patients, because the data bears out that what we say matters to them. And also the data shows that for those of us surgeons and doctors that don't know the data, we tend to be much more accepting of contralateral prophylactic mastectomy, and I think that makes a point in itself. If we don't understand the risks and we're like, oh yes, you should just go ahead and have it for whatever reason, symmetry, or that our patients will listen to us. And I think that is one of the reasons why there's so much variation depending on where you are, particularly in the United States. So I think it's quite important how we say things. The other thing I think that can help the most is that tincture of time. I think most patients walk into my office requesting bilateral mastectomy for their, unilateral cancer. And so I think one is bringing the focus to the cancer that they have is quite important. And if you just keep focusing on that cancer and the treatment of that cancer, I think the more time that passes, whether that's with neoadjuvant chemotherapy, or now showing data that there's improved survival with lumpectomy over mastectomy, there's a lot of different ways that you can get to that kind of mutual shared decision. But patients listen to us, so how we say it is important.
So Andy, what if we have a patient who doesn't want to listen to us, who's hell-bent at having one? What do we do?
I think that's a very difficult question. I've got a little phrase I say to them. They'll say, I'm willing to take the risk of a complication with this operation. And I'll say, well, I'm not willing to take that risk. And there's two of us in this relationship. Now, I had a patient who was insistent on having bilateral DIEP flaps. And she had a primary cancer on one side, young woman, and node positive, you know, she really didn't need to have all the issues of complications with bilateral DIEP flaps done immediately. But she did find a surgeon in another city who did it. And one of the flaps fell apart. She got wound dehiscence in her abdomen. She spent several days on an intensive care unit, and it delayed her adjuvant chemotherapy by about 4 months. Now, for that patient, that has almost certainly impacted her life survival, almost certainly. And I think what we need to do always is never to let a patient push us into a situation of doing something that we know is either intrinsically not going to benefit them, or it's against the guidelines and it's against the data. And so use your MDT, put your MDT between you and the patient. So you've always got that buffer. And you can always say, well, this is my view, and we've discussed it at the MDT, and the MDT supports this view, and we want the best for you, and we're actually not thinking that this is the best, and it's not the lowest risk.
Do to your patient what you do to your family, to your wife or to your daughter. Because in Brazil, what helps us to avoid this kind of unnecessary surgery is when we talk about when the patient had already done treatment for breast cancer, she already had risk reduction. So it's really, yes, you had at least 50% of reduction of your risk when you did chemotherapy, hormonal therapy, and so on. So this is something that it's necessary to say, using the right words and show the patients the risks that they have when they go to unnecessary surgeries. And here, here in Brazil, maybe it's worse than in other countries because of this culture of plastic surgery, of aesthetic surgery.
Vishaka?
Yeah, I just wanted to share my experience from the genetics point of view, because you can imagine we get a lot of women coming through who actually 80% of them will not be at high risk, and often they walk in to the genetics clinic with an idea in their mind because of that anxiety and risk perception. And coming to your point, Ash, about, you know, if we don't look after them, they might go somewhere else and get suboptimal care. I think it's important to keep the conversation going with them. And over time, often that's helpful because whatever's driving that anxiety may come to light and then give us that light bulb moment about what else might help them before they make that decision or before they go elsewhere. It can take time and it can feel often like it's not going somewhere, but actually it's worth a shot.
And that's why a clinical psychologist is an important part of a BRCA MDT, because
Yeah.
they will unlock these little nuances that you and me miss because of busy clinics. You can see Andy nodding away, so he agrees with me. Great. So I'll hand back to Yazan now for last thoughts and thank yous and everything else.
Torturing everybody else. Now I just need to ask Rachel, is the MDT flow, is it any different, for example, in the Marsden, different than anybody else, or is there the set structure in the UK now for all the MDTs for genetics?
So at the Royal Marsden, we don't have a formal risk reduction MDT. We have a sort of pathway that the patients go down, and then we have individual discussions with MDT members if they're a complex case. And we can also talk about complex patients often in our oncoplastic MDT, particularly if it's a complex discussion about the surgical approach. I think one of the, slightly off topic, I think one of the interesting things that I think is going to become more and more relevant in the next few years is patients who are diagnosed as a BRCA carrier when they're diagnosed with an ovarian cancer. Now, as the prognosis of ovarian cancer has changed a lot with the advent of PARP inhibitors, I think us that do risk reduction surgery are now seeing patients who have been treated for an ovarian cancer that was often, stage 3B, who've now had PARP inhibitors and they're doing well 5 years later, are coming and asking for risk reduction surgery. And I think those are really quite complex patients because of those competing risks of their ovarian cancer diagnosis. And we don't really know the long-term outcomes of patients who've been on PARP inhibitors for ovarian cancer in the sort of long term. And a lot of the medical oncologists who deal with gynae oncology are quite positive about the future. So I think those are going to be some of the complex questions where you really need to discuss with a wide range of people, or geneticists, medical oncologists from the gynae point of view, and other team members, because if they've had a lot of abdominal surgery, they may not be suitable for autologous reconstruction as well. So I think as we learn more and as treatments for breast cancer and other cancers get better, these complex questions really do need an MDT.
This is a great point, because many ladies don't necessarily have only breast cancer in the past. Some might have had an ovarian tumor with their BRCA, some might have had a sarcoma with their TP53, some ladies might have had a different type of tumor. So you need to know the survival and the outcome from that type of tumor before you embark on discussing risk-reducing surgery for them. Ash, you have your hand up. You want to take over again?
No, I'm not taking over. The question you asked, Rachel, actually, we could ask Vishaka, because Vishaka actually chairs the BRCA MDT that we have, or the genetics MDT now. We also call it HBOC clinic. We don't call it the BRCA clinic anymore. So Vishaka will correct me. Before she corrects me, let me say that. So, Vishaka is quite a strict little clinician that we have, and she runs a very, very tight ship. So Vishaka, just if you enlighten us about how we run our BRCA clinic and the MDTs, that would be kind of helpful, I think.
Yeah, of course. We're really fortunate to have such amazing clinicians, including Ash and Hisham, who input into our MDT. All are patients, both male and female, and that's a really important point here, because actually families with high-risk gene mutations, BRCA and others, there are risks for men as well that need discussion, but also reproductive risks for young adults who might be thinking of having children of their own. So as they are detected with these high-risk gene mutations, they are referred into the HBOC service, so Hereditary Breast and Ovarian Cancer Service, which we also need to change, because I've had feedback from the men that they feel left out, but it's getting longer and longer, so we'll think about that one. Once they're referred to us, they are all contacted by a team of genetic counselors to go through various options and clinicians that are available, but also to think about the age appropriate clinical management that we would be recommending. So for example, if there's a 25-year-old, it wouldn't be appropriate for us to talk to her about having a risk-reducing bilateral salpingo-oophorectomy, for example. So we would probably delay her conversation with the gynae oncologist team, for example. So once we've done that triage work, once we've got all that we need, we see them in a one-stop clinic where they have the opportunity to meet the genetics team, breast team, Ash included, our plastics team as well, clinical psychology, research, gynae as well. And we discuss all our patients at the end of the day. And actually that's really beneficial, because often as the day evolves, their decision-making evolves. So what they might tell me at the beginning might be different to what they end up telling Ash. And it's really helpful to put it all together for them at the end. We then create a letter with each clinician inputting a paragraph, so that at the end of it, when that letter gets to the patient, they have a really nice sort of collated decision from the MDT, which takes them through all the risks and options, and then they can go away and think about it. We run an open door policy, really, so all our carriers can contact us at any point through their life. They don't have to go back to their GP primary care and get referred. However, obviously, once they've been inactive for 2 years, we sometimes run into trouble. So we might need their GP to give the nod to continue looking after them. The other thing to add is that this is a really young cohort and it's getting younger. And a lot of them are looking to access reproductive options like testing in a pregnancy or even pre-implantation genetic testing. And again, we are really lucky because we are the national centre to deliver pre-implantation genetic testing at Guy's. So we can really quickly link them up to our PGT team to have a think about their eligibility and whether that's an option for them. We have a patient register as well. So we actually call them up at certain time points to discuss the various clinical options. I'm sorry, that's taken much longer than you probably would have liked, Ash.
It's lovely, Vishaka. And we have lots of comments online. We have Prof. John Benson from Cambridge who says, patient education is the key here, which is what you mentioned now, Vishaka. And we have lots of interaction online, lots of other questions. Is there any comments from anybody from the panelists? Because we're now coming closer to 7 o'clock. Anybody wants to raise any point, to discuss anything specific about risk-reducing surgery? So I cannot thank you all enough for taking the time and giving up your time to prepare the talks and to be with us all this evening. It has been great. And thank you for everybody also that has joined from all across the world. Remember, this webinar will be online on the YouTube channel for the next few weeks' time. Everybody that has attended will have their certificate sent to them in the next week or so. Please don't start emailing me in the next half an hour. I'll send it, just give me a few days. You'll get 1.5 CPD points from the Royal College of Surgeons of Edinburgh, but please fill in the questionnaire once the webinar finishes. We have 2 other webinars already planned. The next one is on margins. We have the pathologist Trine Dran from Denmark. We have interoperative 3D imaging by Michael Alvarado from the USA. We have surgery from Karina Cox from England, and we're still looking for an oncologist to talk in that. And we have another webinar about conference updates, and that's also very interesting. We have Prof. John Benson from Cambridge to talk about San Antonio. We have Michael Genant from Austria who's going to speak about St. Gallen's. He's the co-chair of St. Gallen's. And we have also Ramsey Cutter is going to give an update on ABS. Jill, we need to find somebody for ASBRS. So we will need to arrange something. One webinar is on the 10th of June, one on the 24th of June. So for people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the Middle East and further east, have a good night. Thank you, everybody, for joining.